course, we will not do most without having the moderator, Dr. Marina Campodónico-Frisch. She is a trained pediatric dentist at the University of Chile and is a member of Fundación GAN's multidisciplinary CCC team. She's in demand as a conference presenter and teacher and is co-author of chapters in the book Tratamiento Interdisciplinario de las Fisuras Labiopalatinas. Dr. Campodónico is a long-term partner in Transforming Faces capacity building work and a member of Smiles Train's South American Medical Advisory Council. So Marina, the room is yours.
Okay, thank you, Abdon, and welcome to everybody. It is a pleasure for me to be part of this roundtable. I like to express also my gratitude to the group of Solutions for Comprehensive Cleft Care for inviting me to be part of this great initiative. They have really done incredible work in a short period of time, and I hope we can do the best with this opportunity and take home a lot of hope and the great ideas. We will listen to the panelists, and afterwards we will have time for discussion, as Abdon said. And so I invite all the panelists to present the presentations. They have all prepared interesting presentation. I had a look to them and they're really interesting. They have this personal point of view of each country. And I hope there will be for the most benefit of all of the participants now. So first of all, we will meet Dr. Rocio Lu. She works in Lima. She is professor in Department of Medicine of Oral Health and Maxillofacial Surgery in the University of Cayetano Heredia in Peru. And she is also the head of the program Creciendo, which works with cleft patients and also partnered with Smile Train and Transforming Faces. So Rocio, it's a pleasure to have you here, to see you, and all the screen is yours. So Rocio, you must
unmute
your microphone, please.
Rocio?
Yeah, oh, thank you, Marina. It's a pleasure for me to be invited to this meeting and being part of this great initiative. I hope I could contribute to the topic to this in this challenging time. I thank Transforming Faces for the invitation, and I feel honored to show a little bit of our work. It is where we work. Work with patients, with students and health staff at the university, and we're trying to make a CCC treatment for deaf patients. As Marina said, my program is in Peru, in Lima, the capital of Peru, and almost all our patients are in Lima, but we have 30% of them in the other sides of the country. Our partners are the university, Smile Train, and Transforming Faces. Here I have some questions I have to answer, I think. The most significant impact of COVID-19 in my region is that we have a national crisis in health and in economy. We had a long quarantine that impacted our economy, loss of incomes and jobs. 67 point was almost 68% of our families that support the project are in social risk because they live in overcrowding and most of them are unemployed right now. Our health system was collapsed before the pandemic, and even now the system cannot attend the health demand. By September 4th, we had about 700,000 confirmed cases and about 300 deaths. Our facilities were also closed since in March 16, and we are limited financial resources, and all the treatment stopped, and we had to try to make things in another way to keep treating in following the patient. Well, our experience with oral health care during COVID so far was just online. We are doing online assessment for orthodontics, for NAM, for all the treatment we are giving online. NAM therapies, follow-up cases. We are organizing conversations of oral health prevention for parents and kids. And we are having to promote contact with parents for counseling and support. We are trying to do also online training of NAM therapists for orthodontics living out of the city, because we are so many patients living out of the capital. So they need NAM therapies, and we need to train some people outside from the capital. The key challenge related to oral care we are seeking to overcome are about these four. No? One is to start oral care attention, because all the facilities are closed and we don't know when we'll be open again. We have also to manage the risk of exposure. We have to achieve also a safety transportation for patients and all the professionals. And we have to achieve an online oral health prevention program. That's the challenge we are having right now. About the safety protocols for implementing face-to-face treatment, right now we are not having any protocols implemented because everything is closed. But the protocols that could be implemented will be the ones proposed from our health official authorities on my country, and could be complemented with suggestions of national or international guides for COVID-19 risk control.
Just 1 minute left, Rocio.
Well, 10 minutes? 10 minutes.
Just one minute.
Oh, sorry. And we could apply, well, here ones are, we are planning to manage the backlog. Basically, we have to, the university is changing the license of one of the clinics, so to manage the backlog cases, not only ours, but the university have a lot of backlog cases also. All the surgeries are backlogged also. We have to direct all the patients to the system to be attended, but it's closed. And also the same thing for dentist attention, that we have to do that. Everything is closed, and we are trying to make them an oral health prevention program. And well, we need sources for safety, um, for safety purpose, and just all the masks, the facial shields, and the PPE clothes, and also for our program that we're trying to make prevention, and for the I found that we could manage a little bit the aerosol produced by the dentist work. So we could use acid, hypochlorous acid, you know? And so
Lucio,
we
you have to
could find,
close your presentation. We are
yeah,
on time. Please.
that's all.
Thank you very much.
Mm-hmm. You're welcome.
Thank you very much, Rocio. I'm sorry, but we have to stay on track.
Okay, no problem.
Thank you. And afterwards, we will have the possibility to do more suggestions and comments about the situation. Thank you very much. Now we will welcome Dr. Leikova. She is a consultant orthodontist in the Medical University Hospital in Plovdiv in Bulgaria. And she's also a member of a multidisciplinary team of comprehensive cleft care. And we welcome you to our panel from today. Please, Radsto.
Thank you.
You're welcome.
It's my pleasure to be part of this event. Thank you for the invitation and for the opportunity to share my experience as a clinician, as a member of a cleft team. Next slide. Yeah.
Thank you.
In Bulgaria, the pandemic COVID-19 is a part of the worldwide pandemic of coronavirus disease. The country started state of emergency from 13th of March until 13th of May. From last update from September 2020 is that there are about 17,000 officially confirmed cases spread throughout all the Bulgarian provinces and 677 recorded deaths. There are some travel restrictions, and people who want to travel between cities must have signed document with traveling for a special reason. About the situation with the orthodontic treatment in our country is that the government, we don't have financial support. And next slide, please. And the orthodontic treatment is paid by the patients or parents and is co-funded by some organizations. Our cleft team consists of a surgeon, orthodontist, speech pathologist, psychologist, and nurses specialized in feeding. Our country is about 7 million people. Next slide. And who is involved in the orthodontic treatment? 10 years ago, I met Professor Yuri Anastasov, a plastic surgeon from the Medical University Hospital in Plovdiv, and he invited me to be part of his cleft team. So from 2010, I'm a part and a consultant orthodontist in the cleft team. Every Friday, we have free consultations in the Medical University Hospital. and where all of the specialists in the cleft team are together and see all of the patients that are coming. Also, as an orthodontist, I'm a coordinator, and my experience is about treating more than 30 cases per year. Also, we have the support of dentists and orthodontists from different regions who support us in treating few cases. About the orthodontic protocol, we don't use pre-surgical orthopedics or orthodontic surgery.
Of the sagittal
So our priority group is for maxillary expansion and preparation for secondary alveolar bone grafting. Next slide. Thank you. The challenges that we have during the pandemic time was that the private dental practice was closed for 1 month. Only the hospital were closed for 2 months for the regular consultations. This is the photo shows an overview of Bulgaria and all the main cities. With the arrows, the middle arrow is Plovdiv. It's the second biggest city and where the Medical University Hospital is located. And every Friday we meet there with the cleft team. Also, I treat some of the cleft patients there. The red arrow is Sofia, the capital, where I live and is located my private orthodontic practice. And also the blue arrow is the third biggest city where my family dental practice is. So I also treat patients in the three cities. This was one of the challenges during the pandemic time with the traveling restrictions, because some of the families were worried about how to continue the orthodontic treatment and when, and they wanted to come to continue the appointment, and the others were preferred to stay at home. Next slide. This is a photo from my private orthodontic practice in Sofia in April. So this is the reality now and how we work nowadays. Of course, preventive measures were very important for us. Now we increase the preventive measurements and also the patient evaluation and screening. We use protective masks, face shields, gowns and gloves, and also mouth rinse for the patients during some procedures. Next slide. The coronavirus pandemic swiftly changed our daily routines. We were trying to manage all of the patients, and also we take some managements like minimizing the number of patients of the day and also the number of accompanied people. During this time, I have contacts with all of my patients about their appointments and ask them, is there some emergency cases that we have to manage. Also, some of the new patients that are waiting for their treatment plans, we have consultations, video consultations, or we have some phone calls. And also, because I treat the patients for many years, I have close contact with all of them. Next slide.
1 minute left.
Okay, this is one of our tools, our electronic medical record that we use in our daily routine. Now in this pandemic time, it was very important because this is a platform that specialists, patients and parents can upload photos, x-rays, and also ask questions or write about their problems. And I receive message on my email that I have a message and I can answer and contact with the patient. Next slide. Some improvements that we made during this time: personal protective equipment, of course, doesn't solve the problem with the aerosol being produced. So in some procedures that we have, for example, for oral cleaning or cleaning the resin, we use aerosol shield. One of my friends and colleagues, an orthodontist, invented and introduced this type of device. Some improvement in the waiting room of the office was a lamp, UV lamp, hanging on the floor for disinfection of the airflow. Next slide. As a conclusion, I can say that the findings of this situation reinforce the importance of good work practices, also including hygiene, infection control, and personal protection. Also, this time again show us that orthodontist-patient relationship and communication was also very important. And this relationship, of course, released the stress and anxiety and increased the trust and energy between the people. We have the time to improve our treatment protocols, to view and reorganize patient records. And of course, we have the time to talk with the specialists in the cleft team for long discussions and to improve our cleft care. Thank you for the attention.
And that's the team in Plovdiv, or
Yes.
the team in Bulgaria, let's put it that way.
Yes.
Thank you. Marina?
Thank you, Radost, for your presentation. Very interesting. I think a lot of messages we can take from there. And now we go to our next presenter, Dr. Puneet Batra. He's Vice Principal Professor and Head of the Department of Orthodontic and Dentofacial Orthopedics, Institute of Dental Studies and Technologies in Modingar, Uttar Pradesh. He's also member of Smile Train India's Advisor Council and Dental Council of India. And we invite you, Dr. Batra, to do your presentation, please. Are you there?
For the invite, yeah. Can we move on to the next slide, please?
Thank you.
Next slide, please. Yeah, please, can you just continue?
Sorry?
Continue, just press the key because my slide,
Okay, go.
I've been working since the last 22 years with cleft patients and with Smile Train since the last 15 years. Next, please. And, you know, COVID has had an impact on the way we are going to treat cleft patients forever. Next, please. So we have started our work with SOPs and protocols in place. Next, please. So the post-COVID scenario means that we are looking at patients coming from potential hotspots. Next, please. Proper pre-treatment telephonic reception screening is being done. Effective patient management is being done. Next, please. We are decluttering the patient appointment timing and also disinfection. So disinfection has to be done in quick time when the patient comes and goes. Next, please. So the challenges, like the earlier speaker mentioned, is not about the PPE. The challenge is about risk elimination and substitution. Next, please. The challenge is to use technology for tele-dentistry. Next, please. So we need to be slow, steady, and cautious in our approach. We need to counsel families and explain the changes to them by video conferencing. We need to use technology and alternate treatment methods. Next, please. And we have to have a rock solid treatment protocol. Next, please. So proper screening, assortment and triage, and minimal procedural risk. What we need to have is this flow chart of red, yellow, and green, that is cases which need emergency care and cases which do not. Next, please. Next, please. So clinic needs changes. It needs to have proper telephonic appointments. Next, please. Proper reception and sanitization. Next, please. Collection of phones and appliances at the reception. Surface disinfection. Next, please. HEPA air filter systems Next, please. High humidity air conditioning. We need aerosol minimization with high vacuum suctions, negative pressure operatories, and delineate separate room for lab work. Next, please. To approach patients, remember there is a difference between crisis and contingency, meaning that we should not be overboard with the crisis. We need to understand when the number of cases are rising and when the number of cases are stable. Next, please. The surgeons have made a very good score. It's called the MEND score, wherein they decide when to do, cases which are not for emergency, and another where they know when to do those procedures. So we also need as dentists to work on that. Next, please. We should have minimum 6 feet barriers between the operatories. Next, please. So a barrier is a must between patients. Next, please. We need to follow proper masks, gloves, eyewear, proper pre-procedural mouth rinse, high vacuum evacuators, and high efficiency air room filters. So the air quality is very important. At least 12 cycles of air circulation is a must when you are calling your patient in. Next, please. This is the protocol we follow from the reception to the patient entering into the with the clinic. This is what kind of PPE, what patient, and what procedure has to be followed. Next, please. So for NAM, we have changed our protocol. We are doing dynacleft, nasal elevators. We are giving aligner, NAMs, minimum patient appointments. Next, please. If adjustments are required for the Grayson, we are doing it in one go. We are doing the aerosol procedures in a very well controlled laboratory environment. Next, please. And we are following up patients with video conferencing. If the NAM is over and the surgeon is not operating, we are keeping a wax stabilization for the patient. Next, please. Next, please. For the SABG patient, we have made a protocol, the traffic light system. Patients which need emergency care, which need to be followed up, and patients which can be on hold. Next, please. So this chart is telling us which patients need immediate care and which can be delayed. Next, please. We are preferring for face mask patients, oral hygiene instructions. We are giving them very strict ones, and we are trying to reduce, the traction force if they are not doing well. The screw activation is being stopped if they are not able to follow up instructions, and elastics are being given for non-contact means at the office. Next, please. The orthognathic surgery is not the priority at the moment. We have made a list of emergencies: a dislodgement of an appliance, an impinging wire, a broken band. These are the emergencies which are to be handled at the first go. Next, please. And like I mentioned, the orthognathic surgeries can be deferred. Next, please. So pre and post corona things have changed. Next, please. Next, please. So severe cases need to be prioritized. Next, please. Traffic light coding is to be used for all cases. Next, please. Tele, dental, and software management. Next, please. Alternate methods like dynacleft and decluttering of patients using a nickel palatal expander instead of a quad helix. Next, please. Surgical treatments more likely to be affected due to deferrals. Next, please. So we need to reassess and readjust. Next, please. Obvious need to restructure and update certain items in our practice. Next, please. Long-term preparedness is more important. Next, please. Next, please. Next, please. Modify your hospital and treatment area. Optimize patient appointments. Next. Proceed with caution and care. Next, please. Replan, reassess, and reevaluate is what we are doing. Next, please. So with this, I want to conclude that we have changed the scenario of our work, and this is to continue forever. COVID has changed the way how we are going to treat our patients. It's not now, it's going to be for the next 6 months. Thank you very much.
Thank you, Puneet.
Thank
Marina.
Marina, well, I think all presentations were really very interesting. Some some of our realities are very similar and some are different. I can see Rasto had a very short time of lockdown, different here in South America. At least we have still many areas in lockdown for many, many months really. And this of course generate different situations. In India, I know it depends from the area, how it is implementing in each area of the country. So of course it affects in different form the patients and our reality and how we can go back to work or not, and what we have to create to deal with all the challenges. So I will thank you for the presentation, and I don't know if someone wants to make a question. Nobody has wrote anything on the chat, so maybe you can ask your questions live. Please feel free. Someone?
Yes.
No?
So what is the most challenging part of trying to contain the aerosol? And how do you educate the patients? And what is the new way to receive treatment?
Right. Can I put in few words on this?
Yes.
Yeah, the first and foremost thing is that, we have split the cleft patients orthodontically into phases. The first phase being pre-surgical infant orthopedics. Now, in pre-surgical infant orthopedics, in patients who cannot travel or who are from containment zones where their number of cases are high, we are not giving the appliance. We are giving a nasal elevator, the Dynacleft kind of appliance, and we are monitoring over on the phone or on the internet. We are monitoring the patient. The patients who have come once and we are making aligner NAM for them, they also do not need to come for follow-up. But the patients with appliances, the Grayson appliance, or where we require to do trimming, and aerosol is likely to be generated with the bacterial content on the plate itself. What we are going to do is that we are going to ask the patient to give the appliance to us outside, and the laboratory is totally segregated with high vacuum suction system to remove the acrylic shavings. The shaving of acrylic is being sucked in very well, and the appliance is first decontaminated. It is first placed in glutaraldehyde for some time, and once it is decontaminated, only then it is worked on in the laboratory. So, it's a difficult situation. You are not working as you would regularly do. So what we do is, the first appointment, we sit with the patient's mother and explain them, the family, and explain them that, see, we will be doing it long distance now, but we will help you with the taping, we'll help you with everything. And we show them, demonstrate them, show them a video, we show them the way how to handle things, and then remotely we treat them. So that we are trying to minimize the generation of aerosol. Actually, what research is pointing is that kids, small children, might have high viral load but have no symptoms, but they can transmit it to the public more. So we have to be careful.
Yeah, thank you, Puneet. I think that's a very important point. We have to be aware that we need to disinfect all the appliances before modifying them. I think that's really very important, and that everyone have to be aware about this. And it's interesting how we changed to a long distance treatment. I'm personally always tend to be concerned about, because I'm not sure that the parents will manage the appliances in proper way. But I think we probably have to learn from them also, and to do the best for the children. So Rocio, she talked about, and also Dr. Roth talked about the problem in transport and safety in traveling, no? So maybe Rasto, would you do a point about this?
Yes, yes,
Well,
I
yes.
hear. Can you repeat the question? If
About, because you said that you are traveling
yes,
from one city to other. I can tell you here in Chile, we had a lot of issues, and most of our patients, they couldn't attend to the appointments, and only in private, because in our foundation, we couldn't work until the last month, I think. So we were closed for almost 5 months. So you can tell us a little bit about your experience. Yes.
Yes, in this situation, in general, I go to the cities to treat the patients. Now it was the opposite, the emergency cases, because I am living in one town, and also they are coming. I wrote to the patients a document that they have an emergency situation, and there was no problem outside the cities to come to me and to resolve the problem. So of course, this was only the emergency cases. I cannot see all the patients. And also this was only a short period. It was only for 1 month.
Okay.
Also, I have the possibility to send some, for example, some broken appliances. I choose another appliance that is individually packed, and I can send to the patient and change the treatment protocol, and also send elastics if they're finished for wearing facial masks.
Okay, perfect. And Rocio, what was your experience in relation to the access to the patients and the transport and safety of the patients?
Well, here, the transportation, the public transportation is already open, but is not safe because the crowding, and it's not safe for patients or babies, and so we're trying not to make appointment and make them to move from one place to another, because even the transportation from one city to another is not safe. So that's a problem. Here we are. Everybody that takes public transportation have to use face mask and a face shield.
Perfect. And
Yes.
another question, Punet, you talked about the importance of managing properly all the aerosol generating procedures. You said that you had all the air filters, the EPA filters, and Rados, you showed this appliance.
Yes.
So my question and concern about the appliance, is it really safe for the patient? Because I think it's more risky for the patients than it's safe for you, but the question is it really safe for the patients? That's my personal concern, no? And I think Punet is thinking the same.
I agree with you. Actually, this kind of appliance was made in our country too. And it is popular, on the net, you will find many samples of such kind of appliances.
Fine.
But the problem is that even an extra oral suction or anything which is sucking up the air is not actually helping. We are working in closed operatories. So the most important thing is the airflow. If you are having 12 cycles of airflow in that operatory, the number of aerosols will reduce by 70%. So whatever you might put as a shield or whatever you might use is of not much consequence. There are systems in Switzerland, there is an IQ air system wherein they create a negative suction and a negative pressure in the operatory. But I think that the best way to handle aerosol is to have good ventilation, nothing else. Those 12 air cycles, they are the key. And one more point, Marina, if you allow me, the important point which I wanted to highlight was the traffic light system. Because in my experience, see, the patients who have had NAM or no NAM, there is controversy. Dr. Rados is doing beautiful work without NAM. But the question is about the mixed dentition where the bone graft has to be done. Now the canine is about to erupt. The patient will lose out because a secondary alveolar bone graft done before the eruption of the canine and after the eruption of the canine will definitely have poor bone quality. So I want to mark them in a traffic light system as a red, blue, or red, yellow, or green. That these red cases are my priority. I have to see them first and put them for surgery as soon as the condition allows that to happen. So from my perspective, the biggest take home is to actually highlight your patients in the order of severity of need. Who needs intervention right now? An orthognathic surgery can wait. It's not urgent. You can do it 6 months later, you can do it 1 year later, but you can't wait with these patients. Also, the second group of patients is the ultramic or the distraction cases, which were started pre-lockdown. Those cases are now stuck. They're elastic where their treatment has to be done. So, when we look at the backlog, we have to consider the patients which need emergency care, not just because of a broken appliance, but because of their need for doing the treatment at the right time.
Yes, I agree in that part of the right time is not just an orthodontics, is in everywhere. But as you, Puneet, said very well, having a priority list is important, is to classify our patients in order to that priority list, and also ensure the families that they can wait. And I believe that that's something that probably you guys can share. And I invite Sylvia and Schiffer also to come into the table and express how this part is very crucial in order for the families to understand what is the orthodontic treatment, because sometimes families want it right now, right there, right now. How do you deal with this? How do you teach people how to handle the priority?
Yeah, and sorry, but I would like to add to your comment, Abdon. I would like to add that there's not only orthodontic in the dental area, there's also pediatric dentistry. And so my question to all the participants to the roundtable is how you deal with prioritizing, because at least I work in a center and we only have a limited space at the waiting room. So the waiting room begins to be the first point of how you deal and how you select the patients that you can see. So probably I would like to Sylvia to do your comments, and maybe then the other people, please. You must unmute, Sylvia. Abajo a la izquierda, el micrófono. Okay.
I think the first is to be close with the patients, with the group, telling them that we are really making the best for them, and try them to understand what really happened. And I think they agree with us that we are really trying to give them the best, and they really understand the situation. The main problem for them, for our patients, is the surgery. They are sad or upset because the interruption of the surgery. The others treatment, they mostly accept them, that it's for a better time. And we follow them with a very continued communication by phone, by WhatsApp, so they finally understand what happened and what could we do, what couldn't we do. So for us was not so problematic, so terrible this point. But also we understand that in the time they ask us for the, like I said in another room, they ask us for the feelings of the children, and we try to to give a response for that. So they really understand we are making the best. And that's why we can explain and make them stay patient. And all the time we are making a communication very close. And I think this is the point.
Okay, thank you, Sylvia. Someone else?
Yeah. Looking for how to handle the face-to-face attention for patients. I found that, for example, hypochlorous acid is called electrolyzed water. It could be used to put on the unit for the high-speed piece, no? And all the aerosol we generate with the practice will start being done by this hypochlorous acid that kills the virus in just seconds. So it looks to be very safe. It's been used for dentistry, for medical procedures, for agriculture, for a lot of things in the industry and also in health. So we have to look the results of the researchers to see if this electrolyzed water could be one of our device to handle the aerosols produced during our activity. Because it's just in seconds hypochlorous acid will work.
Thank you, Rocio. Someone?
Okay.
Can I make a comment?
Yes,
Just
please. I don't
Do
know.
you hear me?
No, I don't. Someone. Please.
Radost.
Radost. Yes, please. Radost.
Yes.
First Rados and then Shifra.
Sorry.
Yes.
Radost, and then after her, you please.
Okay, just to say that I agree with Dr. Batra about the emergency cases who are real emergency cases, but now I have some situations during this severe time that because of the problems with the oral hygiene, there are some emergency cases, because this is something that I can say that I fight with the patients for good oral hygiene. We motivate, because I work with a lot of children, and oral hygiene makes these emergency cases because of inflammation and bad oral hygiene. So when I contact with my patients, I say, wash your hands and of course, clean your teeth.
Yeah. Well, I think this is a problem all around the world. But probably we can, I think at least with oral hygiene, we can use a lot of tele dentistry, because education is something that we can do. Really, we can do it at long distance using videos or WhatsApp or whatever platform you can use. But there is a lot of information that we can use and share with the patients. That's a good point. Thank you. And I don't know who was wanting to talk.
Shifra. Shifra?
Thank you. In our case, you know, in Ethiopia, the cleft lip and the palate orthodontic there is the only one in Addis that serves the whole. So we have a lot of challenge, having a number of cleft patients that comes to Addis. They are traveling a long distance. So during this, since COVID has been announced, we didn't call patients that are coming from far distance. What we have done is we tried to inform the nearby dentist, because we don't have orthodontists in the countryside, it's very few, to follow up, and if there is a severe case, for example, if arch is removed or some elastics are torn, or if they have some detached single brackets to rebond at nearby clinic in the area where they live. If we call them to the capital city, they are traveling hundreds of kilometers, and the contact or the contamination is very high. So what we have done is to areas where there is, in main cities where there is an orthodontist, we tried to contact the orthodontist there to take care for emergency cases. The others we have tried to contact through telephone, the family, those who carry rapid palatal expander or quad helix or braces, what problems they have, if there is any detached brackets, or if there is any loose wire, or so then we contact the nearby dentist in that area if we can help them to contain the problem there. Otherwise, we cannot call them because of the distance. You know, the longer distance they travel, the transportation is also very difficult, and the rate of contamination or contracting disease is very high. So we were communicating the nearby dentist and also the family of the regarding oral hygiene setup that we provide them with toothbrush and toothpaste that we got from some donor companies, and we already we have oral hygienists. When they were the first visitors, we do cleaning and we instruct them. But during this COVID time, we haven't used any sonoscaler because of its risk. Okay. So our communication with patients were more or less through telephone and through the nearby dentist. Any more?
Thank you very much.
Yeah.
Yeah, we don't listen you very clearly, but I think we got more or less the overview of what you are trying to share with us.
I believe that what Schiffer is sharing in terms of how do we deal with the transportation and the isolation of other patients and try to get support from local dentists is something that probably we need to explore in the next years if this situation continue. However, that they also create the point of training dentists or professionals in order to know exactly what to see or how to follow a treatment that is controlled by you know, another center. So that's something that definitely it's a good idea, and it will be good to explore more how we ensure that the treatment will be safe and on time for the good outcome of the patient.
Yeah.
What do you think?
Yeah, well, I think we have to find out a lot of new strategies to solve all the problems. And Anna, I don't know if you want to say it by yourself, what you wrote on the chat. Anna? You have to unmute yourself.
Hello.
Hello.
Hello, Anna.
Yes. Yeah. We are here in a low-income country in Madagascar. So here it is difficult to treat the patient with in a distance. So since the pandemic, we were open, and we did exactly what the procedure we had to do till now. But yes, we use all the PP, all the things that we had to use during this pandemic, and it is difficult to apply all of the situation here in our country. So just to tell our experience about it.
It is difficult because it requires, there's not
Yes,
enough
material
supplies,
supplies, yes.
or it's expensive, or the
It
cost
is
has.
yeah, both of them. It needs supplies, and it's also expensive for people here to treat to take the precaution for how to say that, with this COVID.
Yes.
Yes.
Yeah.
And that's something that has been a common ground for all other the
Yeah,
lack of supplies or the procurement.
yeah. Most of the dentists here have no equipment for that. So we need more of these here, and most of the dentists were also closed. So all the young dentists like me have to receive all the patients who need emergency in the town. So that's why we had to open since the pandemic. Yes.
Yeah, well, that has been also a big point. We ran out of stock of some protective
Supplies.
equipment for a
Yeah.
while, and the prices rised in an incredible way.
Yeah.
So I think that has been really very universal.
Yeah.
And the other point is we have a lot of emergencies, and we have to solve them. And probably one of the problems that, if we are looking a little bit further, we will have a lot more of emergencies due to the fact that the patients are not having a proper dental care at the moment. And I don't not only mean orthodontic, but general dentistry. I think our patients will have more emergencies due pain, or, as you told, about problems with the gums due to the fact that they are not caring properly. And so when Anna was talking, I just was thinking that one way, and that we probably don't use as a habitual resource, is probably we should form more community people who are giving health support for the people of their community, even if they are not health professionals. So we probably have to form people at the communities that can support to the people, and teaching them how to care about food, about healthcare, general healthcare, about cleaning the tooth, and all that things that probably they can support a little bit the health professionals. And the other fact is that due all the procedures we have to do now, we have to distance our appointments. So we have, instead of having a patient every 15 or 20 or 30 minutes, we have now patients every 1 hour. So the amount of patients we can attend will be less than before. And before, we still had the problem that we couldn't see all our patients. So I think we have to find a way to provide some kind of care to the patients. They are in the green area and are not a priority for us. So we think we have to think about how to do it. Nadia, you are raising your hand.
Yes. Hi, everyone. Thank you so much, Marina.
You're welcome.
I am a program coordinator of Operation Smiley Madagascar. So I'm going to speak not in terms of medical side, but more into the general people maybe, and to the patient side as well. So in terms of context, just to want to react and add to what Anna said about how it's not possible to make what is it called?
Telemedicine.
Telemedicine.
Yes, telemedicine. Madagascar is, I mean, most population in Madagascar live in countryside. So first, there is not much access to internet. Internet is really a privilege for people here. And as people live in countryside, they don't know much about dental care. They don't have access to health care. So that is not really one of the option, I would say, for now. If we just look at the, if you just filter the population of like, okay, the city, yes, but that's gonna be just like very, few people. So this asks a question of like, okay, what kind of strategies can we then adopt as for us and many countries who don't have this possibility? So yeah, just want to share that kind of questions because with the COVID, people are afraid of the virus, so they are afraid to go out, and they're afraid to go to the doctors as well. So they prefer to stay home and self-medicate, which can increase the risk of infections, of viruses. So there was, I think, less of like medical follow-up during that time. So if we consider what the COVID has brought, the situation is more complex than before. So there's a lot of questions to ask. And as for us, for Madagascar, for example, we are now doing a post-operative, post-operative trip to check our patients from last surgery in March. Usually the patient come in one place, but now we come to them because of the COVID. So we have to travel ourselves to limit their travel because it's going to be too much risky for them. So it's us who come to see them, and that gives a lot of different perspective, and we see really what the reality of the patients are. So yeah, that's just the point I want to make. Thank you.
Nadia, thank you very much. How do you see the increase in costs from your perspective, not from the medical or orthodontic? How much challenge you have in that perspective?
Thanks, Abdon. You mean by opting for the mobile post-operative?
Yes.
Thank you. That's a very great question. So before opting for this, we have, the cost would be relative to patients, because the patients' costs, the patients come from all over the 20 regions of Madagascar. So the practice before they come to one place, and then we reimburse their transport fees. We pay for their housing and for their food. For this time, it's going to be the team. And if the post-op was before for just 2 days, this time it's going to be for longer days, which is for about more than a week. The cost is higher if we just have to consider for the post-operative itself in terms of supplies, in terms of time, because we had to have surgeon, one of our volunteer to come with us. So it needs more. However, what we adopted was to do other activities than post-op. For example, we combine post-op with awareness, so we can reach other regions while respecting all the, all the measures. We can visit and develop our partnership with local institutions, hospitals, and more. So in terms of how we manage the budget, we had to combine different activities, 2, 3, 4 activities basically to cover everything. Otherwise, it wouldn't have been possible. I hope it answered your question.
Thank you. Thank you.
Pleasure.
Thank you very much, Nadia.
Yeah, well, thank you, Nadia. I think we have all more or less the same problems, and in some areas the economical issues are stronger or more a problem than in others. But finally, we all are trying to find the way how to get to our patients and give them the proper care. So I think there have been some good ideas, and I think we need to create more ideas to reach all our patients in the proper way. I think we only have 2 minutes more to go, so I really would thank to all the panelists. I think it was really interesting to hear the different views and the different situations that you are living. It really has been challenging for all of us. I think we really have to be creative, and as Punet said, we have to teach people how to fish and not always give the fish. And I think probably one of the things we must learn to this, and I think institutions like Smile Train or Transforming Faces, they are really always trying to tell us that we have to have the tools to teach others and to extend our knowledge so that there are more professionals and probably, as I told, not professionals, probably people in the community that can give us support in these situations, because probably this is just the introduction to the new way we need to learn to live in our planet. So we have to really learn from this situation, and probably not judge each other, but better try to support each other. And this means each other, we professionals, our patients, as Nadia said, the parents, how to give them support at long distance, how to create new tools to reach people who don't have the technology, because that's also a big challenge. And we have to care to all of our patients, and not only the ones who are close and it's easy to provide the care. So thank you for all the inputs, and also thanks for solutions for comprehensive cleft care that has given us this opportunity. And I really would like to invite you to maintain the Kiko chat and to put your opinions there, because this will help us to find new solutions and to share all the information with all of you. After the conference, we will have a document, so probably we can do some research afterwards or something. And it's important to share opinions and to have access to more information. Abdon, I don't know if you want
Thank
to.
you. Thank you for.
Thank you, Abdon, because you really have been a big support, and also Samantha, who was doing all the registering, the screening of the conference. So thank you very much.
So thank you for all the participants. Without you guys, this will not happen. I will thank you so much to the panelists, Maria del Rocio Lu, Rodos, and Punit. The insight, the learnings, the sharing, that's something that is very encouraging to continue facing this situation that is not just in one country, is all over. And Serena, you are amazing. I saw what you had written in the document. It's impressive. Thank you so much. And Marina, your guidance, without you, this will not happen. So just to finalize, in a couple of minutes, it will start the closing plenary. It's looking back, moving forward. It started at 11:40 Eastern Time, 15:40 GMT. And in the meantime, please go to the coffee break room, stretch your legs, drink some water, keep hydrated, and we'll see you soon. Thank you.